In this video, we are going to be looking at the topic Ludwig's angina. Hi, I'm Sharon. I'm working as an associate professor at M College of Nursing. The following are the objectives that we'll be addressing in this video. Ludwig's angina is an acute, rapidly progressing cellulitis involving the floor of the mouth. It affects the submandibular, sublingual, and submental spaces bilaterally, and it is characterized by diffuse inflammation, not a localized abscess in the early stages. It is rapidly spreading and can cause airway obstruction. Thereby, there is a high risk of airway compromise, making it both a medical as well as a surgical emergency. Let's look at the historical background. This was first described in 1836 by Wilhelm Friedrich von Ludwig, a German physician, hence the name Ludwig's angina. Initially, it was associated with high mortality due to lack of antibiotics and airway control. Now, advances in airway management, antibiotics, and imaging have significantly reduced mortality. Let's look at the relevant anatomy. Submandibular space divided by mylohyoid muscle into the sublingual and submaxillar spaces. The mandibular molar roots lie close to these spaces, enabling easy spread of infection. And the edema causes posterior displacement and elevation of tongue, narrowing the airway, causing the obstruction. Let's look at the risk factors and etiology. Poor oral hygiene and untreated dental caries, diabetes mellitus, malnutrition and alcoholism, immunosuppression and delayed access to healthcare. The primary cause in 70 to 90% of the cases is dental infection of the second and third mandibular molars. Other causes include oral trauma, mandibular fractures, silodenitis, which is inflammation or infection of the salivary glands, post-dental extraction infections, peritonsillar or retropharyngeal infection. Let's look at the microbiology involved. It is usually polymicrobial infection involving normal oral flora. The aerobic organisms involved are Streptococcus viridans and Staphylococcus aureus. The anaerobic organisms are Bacteroid species and Fusobacterium species. Let's try to understand the pathophysiology. The infection spreads in loose connective tissue of submandibular and sublingual spaces. Bilateral involvement is found to be typical. Rapid swelling occurs, which causes the tongue to elevate, and narrowing of the airway occurs. Death usually results from asphyxia due to the airway obstruction. Coming to the clinical manifestations, general symptoms include fever, chills, malaise, and toxic appearance. Local symptoms include severe floor of mouth pain, dysphagia, drooling, and muffled voice. Brawny, non-fluctuant swelling of the submandibular region with tenderness occurs. Bilateral neck swelling, tongue elevation, and protrusion and trismus, which is otherwise referred to as lockjaw. The late signs include stridor, cyanosis, and respiratory distress. So how can we diagnose Ludwig's angina? It is primarily a clinical diagnosis. CT scan of the neck with contrast can be done if the airway is stable. Lab findings show elevated WBC and positive blood cultures. The differential diagnoses to be considered are peritonsillar abscess, angioedema, and epiglottitis. Let's see the principles of management. Airway protection is the first priority, and control of infection with antibiotics. Surgical intervention when it's indicated. Supportive nursing care. With regard to airway management, early airway intervention prevents sudden obstruction, and the options include awake fiber optic intubation or tracheostomy. An emergency airway is required in the presence of stridor and hypoxia. This picture shows fiber optic intubation, which is a crucial airway management technique using a flexible bronchoscope to guide an endotracheal tube into the trachea, especially for difficult airways where direct visualization fails. And this can be done even when the patient is awake, with sedation, or even local anesthesia via nasal or oral routes, allowing visualization around the corners to secure the airway when anatomy is abnormal or the access is limited. This is considered as the gold standard for anticipated difficult airways, and oxygenation can be done so that the patient can breathe spontaneously while the tube is advanced over the scope to the trachea. Medical management involves broad-spectrum IV antibiotics covering both aerobes and anaerobes. Common regimens include ampicillin, sulbactam, or clindamycin with cephalosporin. Other drugs that can be given are antipyretics, analgesics, and glycemic control, since we also said diabetes mellitus as a risk factor for Ludwig's angina. Surgical management is indicated in abscess formation or failure of medical therapy, and the procedures include incision and drainage and tooth extraction. Nursing management involves early recognition of warning signs, monitoring airway as well as vital signs, administration of IV antibiotics and fluids, pain management, pre- and postoperative care if surgical management is done, such as drainage or tracheostomy. Patient and family education about oral hygiene has to be given, as it is a preventable disease. Complications that can occur are acute airway obstruction, mediastinitis, septicemia, septic shock, aspiration pneumonia, and death if untreated. Coming to the prognosis, early diagnosis and treatment results in good outcomes. Mortality is reduced to less than 10% with modern management. Delayed airway management worsens the prognosis of the disease. The nurse has to give proper health education and prevention tips. So the first thing that we have to address is the importance of oral hygiene and early dental care. And compliance with antibiotic therapy is essential for cure. Early reporting of facial or neck swelling to be informed so that care is initiated at the earliest. To conclude, Ludwig's angina is rapidly progressive and potentially fatal. Early airway protection is a cornerstone of management. Skilled nursing care significantly improves patient survival. The following are the references. Thank you.